So I'm grateful to Milan for putting me on to a topic where probably I have a better authority to talk on than some of the other subjects where I worked on less. We'll start with the CRP aspect first and then go on to a couple of things about choosing anti-lipid therapy. So this whole advent of rosuvastatin, the gorilla statin with the Jupiter study has put us on the CRP trail, and you are aware of this particular question. But what I needed to highlight is, of course, what Professor Paul Ridker presented at the ACC last time, that when you get down the LDL to less than 70, and then if you get the LDL, the CRP levels down to less than 1 milligram along with, you look at the relative risk reduction, it goes down by about 75%. So this has been the best sort of data we have available on the use of statins in lowering the LDL-C levels, lowering the CRP levels, and the benefit you achieve. Now this is quite superior than what you would have if you get it down to less than 2 milligrams. So less than 1 is better than less than 2. Having it more than 2 is much worse off. But having it less than 2 at any point of time or less than 1 is where you would have a lot of benefit. So this we are aware of. There's nothing new to say. But let me add a couple of other new things which he presented later. In December, he looked at the data in elderly people. We don't have a great wealth of data for elderly people in statin studies. So this is the post-hoc analysis of the rosuvastatin arm in patients who are above the age of 70 years, and you can see that just to prevent one event over the age of 70 years, you need to treat 19 patients as compared to the younger population. So elder they become, more responsive they become to the use of rosuvastatin. To the CRP once again later. I look at these two particular textbooks, and besides trials, you must look at textbooks for the simple reason that they put a wealth of literature together. So you don't get carried away by one trial and then you have limitations of that trial and you don't know how the heck to go about it. So it's good to look at the study, the entire literature available. And these are the two books. You have Eric Topol's Cardiovascular Disease. I follow that for the pattern of choosing anti-lipid therapy. And of course, Chris Ballantyne's Braunwald's textbook. I'm very happy we have been quoted in the 42nd chapter of my work on small dense LDL. So it's been a good thing. Now, let's look at a couple of very important things. That, you see, statins primarily reduce the risk by 23%. That means we have a majority of risk that is still lingering behind. There's something happening there. If you look at the residual cardiovascular risk in various studies, they go on from 60 to 75%. There's a lot more to achieve than just saying you get down the LDL, you get down the CRP. We need to look at the other things also, primarily the triglycerides. I keep this aspect as a very important consideration in this country. When you look at triglycerides, always look at what are the metabolic defects which a person has taken along with him, what he has achieved over his lifetime. The truncal obesity, the dietary pattern, the carbohydrate intake, them do matter. And we do take care of them in a way as a first-line therapy in lowering lipids. But at the back of the mind, when you get a patient of high triglycerides, you must go back to the Fredrickson classification. Now, it's so difficult to remember all this, but make it pretty simple. If you get a lipid profile, as I show you in the next slide, you look at the triglyceride levels. If they are phenomenally high, 1000, 1500, 2000, that's not very common in a non-diabetic. If he's just a normal guy with a reasonable blood sugars, this has come from a genetic pattern. More than thousands will fall in the 1 and 5 type 1 and type 5. Both of them have a minimum of cardiovascular risk with the simplicity that if you have a high triglyceride lipoprotein concentration, the molecules are so large, they don't go and get attached to the vessel wall. So coronary atherosclerosis, premature CAD is almost unknown. What happens is actually pancreatitis, and therefore you treat this patient with a fibrate necessarily to reduce the risk of pancreatitis, not of coronary artery disease. They are coronary artery disease, they are quite off coronary artery disease. That leaves you behind the remaining ones, 2A, 2B, 3 and 4. When you get a patient of high LDL, high cholesterols, which is very common in clinical practice, high LDL, high total cholesterol, normal triglycerides, normal VLDL, normal apolipoproteins, more or less, or elevated apolipoprotein AB, you are dealing with the familial type 2A. This is a patient who requires statin. That leaves you behind 3 situations which you see in clinical practice, and here is that slide. You have 3 patients. Look at these 3 patients. They have come with the same triglyceride, 300, 300, 300. When you get a high triglycerides going beyond your desirable limits of 200 or whatever, try and quickly check out the other parameters. So triglycerides should be your decider of therapy, and you target the therapy with a LDL lowering at statin. How do you do that? If your triglycerides are normal and LDL is high, that's the familial typical dyslipidemia who requires a statin lifelong. If the triglycerides are high, immediately check out the VLDL levels. You have now only type 2, type 3 and type 4 left. The type 4, which is the combined familial dyslipidemia, beta lipoproteinemia, fortunately is rare. So more or less you will be looking at these 2 arms. However, if you do have to look at it, check the VLDL levels. If the VLDLs are very high, if they exceed more than 1/3 of the triglyceride levels, that's this beta lipoprotein. If they are less than 1/3, then probably you are dealing with the 2 and 4. Then you look at the LDL-C levels. This is a combined dyslipidemia where the LDL will also be substantially elevated. If you find them elevated, they require a statin and they require a fibrate. If the LDLs are only marginally elevated, that's the familial combined lipoproteinemia, which is the commonest one which we see in clinical practice. High triglycerides, moderately elevated LDL, moderately elevated cholesterol, low HDL, high VLDL. What is important? You have another patient whose LDL is not absolutely normal, only slightly elevated, whose HDL is low, like this patient, whose VLDLs are low. Check the apolipoprotein B. It's very important these days to check in India the apolipoprotein B. There's no point talking theoretically. We just need to go ahead and do it. If the apolipoproteins are low, this is a patient who will have only high triglycerides, little elevated VLDL, little elevated or normal cholesterol, little low HDL. So high triglycerides, low HDL, but check his apolipoprotein B. Apolipoprotein B are low. This is one patient whose triglycerides, despite being 300, does not merit a fibrate at the start. He must on diet control, he must be on diet control, on exercises. Step 1, he can go on omega-3 fatty acids on niacin. Step 2, he can go on fibrates. This is a patient where the incidence of premature coronary artery disease is substantially low compared to what you get here. Here the LDL is only slightly higher than here, but the apolipoprotein B is substantially high. So the atherogenic profile is very bad. These are the patients where you need to put them on a triglyceride lowering medicine. Now look at these 2 parameters, the CHL and the familial triglyceridia. Let me come back to this. I said this is a patient whose ApoB are high. Here is a patient with the same triglyceride, ApoB are low. Now look at what happens to them. This is a beautiful study. This is from Seattle. It looks at a 20 years follow-up of patients who have a high ApoB, a high triglycerides and a moderately elevated LDL. Here is a patient who has high triglycerides, only very slightly elevated LDL, low apolipoprotein B. Look at premature coronary artery disease. The age of CAD death from 30 to 100, this is a 20-year follow-up. This is the largest ever follow-up done for these sort of arms. And you can look at the complete absence of red dots here. What do we say? You can have a patient of a high triglycerides like 300, but their apolipoprotein B is low. The chance of premature coronary artery disease is low. On the other hand, these are prone to high premature artery CAD incidence. Therefore, you treat them with a fibrate and a statin. In today's date, we have, fortunately in our country, the launch of a low-dose rosuvastatin, with a low dose of fenofibrate. The low dose fenofibrate micronized coming down to 67 milligrams as currently recommended is something which will be very useful for our patients. Now, the simplest thing that you do in a lipid profile before you target triglyceride is minus the HDL from the triglycerides and look at the non-HDL. Even if you look at all the guidelines always have told you that your non-HDL should be 30 milligram percentile more than the LDL as a target. So it's the secondary target. First you target the LDL, then you target the non-HDL cholesterol. So you get the entire atherogenic profile of the patient. If you cannot do ApoB, at least look at the non-HDL. Why? Because we have this meta-analysis which was published this year and looked at what is the relation of non-HDL, and it says that in the fasting state, the non-HDL, which is a simple lipid parameter, represents the pro-atherogenic particles and is a superior predictor of cardiovascular risk compared with even LDL-C. So these are the first two things we look, and then we look at triglycerides and follow the chart. Now, why are we saying this? We must look at the INTERHEART study. Now, I'll present the data not of the entire INTERHEART study, but what has happened in our country. When we say Asian Indians, we are talking of Indians who are staying here. This is the data of the Indians in the INTERHEART study. What was their mean LDL? 125. What was their HDL? 32.5. Mean triglyceride 163. 72% had LDL more than 100 and 83% of our population did not have a desirable HDL. A HDL more than 50 was recorded in 17.7% cases. But I'll tell you two interesting things that happened. One is that we simply forget about the HDL and we have not had drugs and we are not looking at it aggressively even by the guidelines today. Though 83% of us have a low HDL. What are we sitting on? Is it something that we can overlook? The other interesting part is the 17.7%. These patients who had a high HDL, in fact, unlike what we would probably think, were not exposed to a higher incidence of coronary artery disease. We would think they would be immune from CAD. This did not happen in the INTERHEART study. So we still don't know what we are trying to look at. High HDL-C was not protective. Very importantly, ApoB was a better predictor than the LDL-C. ApoA1 was a better predictor than HDL-C. Triglycerides, nor the triglyceride-related ratios were predictive for coronary artery disease in Indians staying in this country, in probably one of the best epidemiological studies which has come out from this country. We must keep these things in mind before we go on aggressively targeting our triglycerides. When we do that, the other aspect that's gaining a lot of importance, and particularly in our setting, is don't then only look at fasting triglycerides. Please see, these are patients where triglycerides have been done in less than 4 hours, 4 to 8 hours, 8 to 12 hours, and after 12 hours, and the relative risk ratio is shown. You see the risk at the fasting triglycerides, and a large number of patients, we are talking of 15,000 patients, is nothing. But when you go beyond the time limit and reach at 4 hours postprandial, the triglycerides give a atherogenic profile. Not only that, it's superior to even a small dense LDL as a predictor of MI. This is a study that has looked at a small LDL-C slice and triglyceride. We have some work which almost says the same thing, that a triglyceride to HDL ratio almost gives you idea if it's right 3.5 or 4 in some of the studies from our country. It's a good enough idea that 70% of your lipid profile is pro-atherogenic. So should you do a fasting or should you do a non-fasting lipid profile? Will it change the way we look at our cardiovascular risk profile? Yes. Paul Ridker's work on the women's health study, 26,330 women, out of which more than 19,000 had fasting, the remaining had non-fasting, 11 years follow-up for these ladies who had no coronary artery disease. What they found was again the same what we have been talking about. The triglycerides and ApoA1 predict the cardiovascular disease when you measure it non-fasting. The LDL-C, the ApoB and the ratio are very important when you try and do them on a fasting stuff. So a postprandial triglycerides is important. Now look at the same data in a chart. Here are these patients' fasting samples and non-fasting samples of triglycerides. These are the levels of triglyceride, less than 90, 91 to 1. Look at the odds ratio of risk, starting from 1, going to nothing, statistically not significant. It just doesn't matter what were your fasting triglycerides. Then when you check out the non-fasting ones, when you jump from 104 to a 70 or 170 and more, what we are trying to target in our country, the relative risk ratio doubles 1 to 2 and the P ratio very highly significant. I think this is an important message which we must try and look at in this country. Fibrates do also have some other benefits. They reduce CRP in some patients, they reduce the LPPLA2, the uric acid levels, the fibrinogen levels. We don't know why this is happening, but there is a little increase in the homocysteine levels after you start using fibrates. Creatinine is only a transient increase and we don't have to worry about it. My last 3 slides on CRP, because I wanted to come back to this and give you the other data. Besides the elderly patients, where I said it's very, very beneficial, at the AHA, Paul Ridker's team also presented the data on women as to what would happen, and the results were extremely good. There is a 46% risk reduction of cardiovascular endpoints in women when rosuvastatin was used. But then, is that the final call? We'll have to think a little more ahead. You see, if you look at the analysis of the entire data, the CRP lowering and its efficacy was completely proved beyond doubt when we did not use any other confounding factor, if you take only the age and sex in matter. But the moment you start using all the other criterias, then the risk factor, the significant risk went down. In fact, if the Framingham risk is less than 10%, I think Professor Nakul Sinha said that yesterday in a meeting in the night, if it is less than 10%, if the Framingham risk, lowering a CRP may not necessarily confer benefit. So, CRP lowering may not be on every chart. US FDA last month has given a approval for Crestor, saying that in patients who have normal LDL and low to moderate risk for cardiovascular disease and have a high CRP, we must use a rosuvastatin. But then the person who sat on the US FDA advisory, Professor William Hyatt, said a couple of very, very knowledgeable things, that defining the population would be appropriate for extended use of statin drug needs to be carefully portrayed in the labeling and marketing materials. You must say which patient will benefit and which will not. It's not a blanket statement. And why I'm saying this? This is a very important paper. It's published in Lancet. This is the largest ever study that has looked at, is CRP a causal factor for cardiovascular disease? This is the largest ever study. It looked at a large number of patients and then checked out what happens with the CRP levels. If the CRP is measured in the population and then you say, here is an elevated CRP with a cardiovascular risk that was 1.63, ischemic stroke 1.44, vascular mortality 1.55. Now you adjust it for fibrinogens, the corresponding risk ratio went down. See, when you adjusted it for conventional risk factors, it went down from 1.6 to 1.37. You adjust it further with fibrinogen, went down to 1.23. 67% risk unadjusted. The moment you adjust it with another risk factor and fibrinogen, went down to 23%. This study says that this means that CRP is not the only answer. That estimation of CRP is a part of global risk assessment and not the complete risk assessment. You must keep in mind when studies are done that unless you adjust it for the other factors, you will never be sure. This is a causal pathway sort of study which is very important because the Jupiter study is not meant to answer that question. It's the largest meta-analysis and the authors conclude that it's unlikely to be a causal factor for cardiovascular disease. This is 1,60,309 patients included from 54 long-term prospective studies. How does Professor Ridker take it? He says, well, it tells two things. It tells you that CRP is still a risk factor and we should all agree with it. And that CRP lowering is not on every chart. We just can't take that as a blanket statement that the whole population should undergo CRP level and everyone should take a statin to lower the CRP. That probably is not the answer which the study would say. I'll end at my presentation here. A small request as a fellow and a helping hand for the Academy of Echo. We have a meeting in Goa. Anybody who would like to register can see me during the meeting or contact me. It's from 11 to 13th in Goa. Those who are exclusively interested in Echo. It's an excellent body and they do a lot of good work. Thank you for the time.